I would want to just know how much time, Adil, we have. 15 minutes. So we're going to speak about the third space endoscopy and what we had in the past, current, and the future, and what are the challenges. They look fancy, easy to do, but we want to know more and dig in the logistics of these procedures. So I don't have any disclosure regarding this topic, and I will start with third space endoscopy. What is it? It's basically a way of getting to submucosal space with maintaining the mucosal layer to do therapeutic or diagnostic intervention, and then you close while maintaining the integrity of the mucosa. The historical aspect started in 2004. It was a wild experience and wild description to getting to peritoneal cavity while using sphincterotome and visualizing the peritoneum, and then you close it with a hemoclip. This is the start of the concept of notes, 2004. It didn't last for multiple reasons. One of them was the financial crisis around that time. In 2006, after that, there was two papers from Sumeima and Pasricha. That was the start of the note and actual peroral endoscopic myotomy to get to third space endoscopy. It was in animal model swine modules, and basically they describe, if you see on the right side, the full thickness myotomy while maintaining the integrity of the mucosa. Later on, where the name of poem went to Professor Inouye from Japan, between 2008 2009, he reported 17 consecutive patients and published in the first human experience to perform full thickness myotomy or peroral endoscopic myotomy with maintaining the integrity of the mucosa with great success and resolution of symptoms. So all the third space endoscopy, or most third space endoscopy, it has the same and similar concept and technique, starting with a mucosal incision, getting to creating the tunnel, followed by myotomy or removing the tumor, and after that, closure, the entry point. There are lots of procedures, esophageal poem, peroral endoscopic myotomy, Zinker poem as well, peroral endoscopic myotomy, and G poem as well. We had case yesterday, followed by STIR, submucosal tunneling endoscopic resections for tumor, including ASD and also PREM. So just go over them quickly. So more than 100 observational studies for POEM, more than 20 patients. The clinical success, more than 95%, as well as the technical success. Higher reflux symptoms compared to the heteromyotomy, but shorter duration. So if you see the ACG guideline, it was adapted and was involved as a first-line therapy for all the three types of achalasia. And the other procedure is G-POEM, and this procedure was described 2013 by Muin Khashab and his colleagues, and in a meta-analysis 2021, basically the success was 61%. There was a heterogeneity in the results and just contradicting data. But we know that idiopathic, longer duration, using opioid, and also psychiatric patient or functional elements have the worse outcome or poor response. It also adapted and was in the recent guideline from ACG as a treatment option that was suggested over no treatment. Don't need to show the procedure. We had it yesterday. The third one is submucosal endoscopic, tunneling endoscopic resection. And it has the same concept. You open the mucosa, you create a tunnel, you remove the tumor. This is one of the leiomyoma we had in the past. And also it was in the guideline for a tumor more than 2 centimeters, less than 2 centimeters in the guideline. You can see here, endoscopic or surgical resection. The Zinker or Z poem also was by Hernandez Mondragons and colleagues as a novel procedure in 2016. As you see on the right side, create a tunnel, expose the muscle on the septum, and make a full myotomy. And then closure, and the response was more than 93%. So the fifth procedure, this is for Hirschsprung disease for patients with chronic constipation and issues with innervations. And it was from single group, from Amol Vapai and his colleagues. They basically reported 9 patients. It has the same concept with full thickness, full myotomy and closure. It's exactly poem, but from the bottom. And the response in follow-up period was actually really good. But 9 patients, we need more data. But it was possible to be done. The other procedures in the field, POEM peroral endoscopic myotomy combined with RAP or fundoplications, and restoration also of the esophagus by making myotomy to restore and for strictures and restore the esophagus, and also the diverticular peroral endoscopic myotomy. So these procedures looks fancy, looks easy to do, but I'm sure and probably you have a question about what are the limitations and what are the things or logistics that may come across your way if you are interested in third space endoscopy. So Dr. Ahmed will continue the limitations. He will discuss the limitation or things probably you will face during this procedure.
Thank you, Dr. Rasheed. Actually, these procedures looks easy because it was presented by a talented endoscopist like you. So usually everything may be easy if it's done in the right way, but some things are not avoidable. So I think the limitation have two sides to look to. One is the expected outcome. Will actually our patient get benefit from these procedures, like patient with idiopathic gastroparesis who have a very low response to GPOM, or the patient with hugely dilated esophagus, even after you open the cardia, symptoms didn't improve 100%, and for sure the invasive cancer, which need a lymphadenectomy, or it's just a technical limitation like in tunneling or in ESD. In tunneling technique, we may have the limitation in how to establish the tunnel, which sometimes is the most important point. Once you are inside and you can find this nice blue color, you can go all through the way. Or if you have a complication like a mucosal injury or a major intra-procedure complication, or if you have a problem to close the tunnel which you already created. This was a nice review. It was done for POEM as the most famous and the most popular tunneling technique. They check 1,400 patients who did POEM. The incidence of failed POEM was less than 1%. It was 0.7%, And 92% was because of severe submucosal fibrosis. When you have these severe fibrosis, it's difficult to establish the tunnel, then to complete your procedures. You can see here, we have a patient with a neglected achalasia, markedly dilated esophagus. We all expect when we try to inject here, we have a severe fibrosis. You can see the mucosa is like a cartilage. Who did POEM can understand this view. So here we just use a tapered cap from Fuji, which is like a cone, and it's stiff. And we start to cut little bit deep to cut the muscularis mucosa, which usually here very thick. So step by step, we can establish the tunnel and go. You can look here, you can see a very nice submucosa, but once we are inside, the procedure can complete it, and this was one way. But sometimes it's more challenging and more difficult. How can I switch off the voice here? I want to switch off the voice. So sometimes it's more challenging. Like this case, switch off the voice for the computer. I don't want the voice from the computer. This is another case, which is the esophagus also still markedly dilated and fibrotic mucosa, and when we inject, no lifting at all. And again, this is the most common cause for abortion or failed POEM. 92% of failed POEM because you couldn't go inside the tunnel from the start. Here we again try to do the same like the other case, and we try to inject and we try to go inside, but it failed. So we present this technique. This technique was presented in endoscopy. We published by our team, me and the Dr. Amr El-Fouli. We gave here the name of initial intramuscular dissection, and we can do in those patients with neglected achalasia. Here actually we start the tunnel inside the muscle from the start. This is our patient, and again it was impossible to go inside. We will change the cap to the tapered cap again, and here we started to cut the muscle at the level of the mucosal incision. This should be very careful. This should be done only in patient with very thick muscle, so we can create a tunnel inside the muscle. You can see here, now we have muscle up and the muscle down, and we go for a while inside the muscle, intramuscular, and we try to move up while we're moving to find the submucosa. So now we started to find the submucosa, and here you can see up is the muscle, down is the muscle. We actually moving inside the circular muscle until we find our way, and this is one of the salvage therapy we can do when we are not able to establish the tunnel, and then we can continue procedure like standard POEM. And we gave this technique the name of Madkour technique, initial intramuscular dissection, and it was published in endoscopy this year. Sometimes we have a mucosal injury. After we establish the tunnel, we have the mucosal injury, and I think with this, see this technique yesterday to close the injury from inside the tunnel. I think we see it live, so no need to show the video. And sometimes we have intra-procedure complication. Here we have a case of a stir. The lesion is in anterior wall, in upper esophagus. What do you think this pulsation is? Yes, it's a pericardial pulsation. So should we go for endoscopic resection in this patient or not? Dr. Rasheed, what do you think? Yes, all right, yes, you can say, all right, I'm sure. So we go for stir. You know behind you is the pericardium, but as Dr. Rasheed say, if you did step by step, and it was careful and cautious, we still can do our technique, isolate the lesion, and continue our procedures, and we should be oriented with the anatomy. Because here behind us, this white structure, actually it's the pericardium. This pulsating white structure behind us is a pericardium, no problem, but you should be careful and know what is around you. and still we can take the lesion out and then close our incision. The last, one of the most challenging complication to close the incision. You know, this is a challenging case we show in the beginning. We managed to go inside and do the tunnel, but closure here is very difficult. One of the nice tips to do this tiny, small opening on each side. Then we allocate the clips inside and close, make closure more easy. Sometimes it's very difficult to close this very stiff, hard mucosa without this small tip. And it's a good for everyone to know this tip. And we do, you can see down here, we do other two small opening, and by this way, we can close the tunnel even with this very difficult mucosa with a fewer number of clips. So one other thing, just one example for the how efficient is the procedure for idiopathic gastroparesis. I think again we see this yesterday to do a double myotomy, so no need to go for. The last thing is for ESD. All this was for tunneling, how to establish tunnel, how to close the tunnel, how to avoid complication. ESD is a bigger issue. Not all ESD cases are similar. This scoring system is very nice, and it tries to classify the difficulties of ESD according to the location. It's on anal verge or cecum or flexure, splenic or hepatic. The size, it's below 5 or from above 5 centimeter, and the circumference and the morphology. And this one is very, very valid to follow to expect the difficulties of ESD, but still, whatever was the difficulties, with proper strategy and enough training, we can go for. This is a circumferential lesion, so according to the score, it takes 3. It's on the anal verge, according to score, it takes 2, and it's involved in more than 5 centimeter, and it takes 3. So by the classification, this is a very difficult ESD. So in the beginning, you should choose which lesion to do, but still, with a proper strategy, we can resect. You can see here a circumferential lesion around 18 centimeter, but it still can be resectable. To Rasheed.
So this is the technical challenges, but remember, there is more than that. So the technical challenge, you can deal with it as endoscopist, but more than that, there is a long process of training and learning curve you need to maintain to be able to deal with the basic cases rather than the difficult or challenging cases. And more than that, you need a team. You don't work by yourself. You need a team, nurses, resident, fellow who's taking care of your patients overnight. So you have to teach them, and you have to educate them to be familiar with these cases. Otherwise, your program or the case will not be successful, because closing the lesion is not the success of the procedure. More than that, you need to have a discussion with anesthesiologist. Maybe if you notice during the procedure, we have a discussion with them about, the CO2 and the oxygen, the blood pressure, the tachycardia, the dehydration they may have during the procedure, and also the radiologist. You need a follow-up image for most of our patients, so they have to be familiar with the expected finding after the resections or myotomy. So you do your cases, but you have to report them. You have to publish your data. You have to publish your result. You have to also to report your complications. So it's very important to keep your data as well. And you need collaborative work. You cannot work by yourself. You need a team, and you need a region as well to work with. So the question come to my mind. You as endoscopist or gastroenterologist, you're very interested in this procedure. You watch the course, you saw the course, you watch Dr. Madkour was doing the case. So what do you think, Dr. Madkour, when can, what do you think about the learning curve, and who is there a candidate for this procedure? Is the interest enough to do these cases?
So this is work. Okay, I think actually, Dr. Rasheed, it's all a matter of the background. We discuss this a lot. We talk a lot about this, and we have a guidelines. We have a very strong guidelines for ESD from the European Society of Gastroenterology. We didn't have a solid guidelines for POM, but I think it's all a matter of background. If we have a therapeutic endoscopist, we have a very good tip control, familiar with clipping and hemostasis, and can manage complication, he can start according to the guidelines. And I think you have some experience in teaching others and in training. I'm not sure if you agree on this.
And is there a number, can I just go to one of the third space endoscopy center and do a certain number to be able to start it at home?
Yeah, so for POM, we can say a number for POM. Actually, a lot of published data, it started from like 70 cases. Some Chinese say need 70 cases to reach plateau, and some others say up to 11 cases. I think less than 20 cases in POM, if you are supervised, is enough. So you can do like 80% of cases, but not this is challenging. But for ESD, it's totally different. It will depend, it's like ERCP now, it's talk about competency, not a number.
So, and do you think the baseline or background training make any difference?
This is the most important. Actually, this is the key of success. If you are therapeutic endoscopist and they have enough experience, you do like 500 cases of large EMR and they do a lot of clipping, it's easy to go for ESD. But if you just have a problem and struggling to reach the cecum in a straight position and to deal with clipping and hemostasis, it's not logic to try to learn how to run before you learn how to walk. So I think this is the key point.
And do we need beta blocker after complications?
Yes.
So
yes.
the challenge again, nature of disease. Remember, so we have all the we manage, the skills, the curve, and we manage. We teach our team. But remember, there is a limitation, the disease itself. It can be challenging. So, and remember, surgery can deal with this procedure. Don't just, think you are a hero and you do this procedure. Surgery is a gold standard for most of the intervention. So remember, surgery is an option and there is no wrong with that. The other thing is referral. It's very hard when I, describe a new techniques, 12 years or 15 years, this is 2009, or 15 years, to describe it over a gold standard. So referral is an issue, and definitely we need help from colleagues. Or, have a just, call me, call Dr. Ahmed, call whoever available in the region just to discuss it. You can send pictures, you can send video, and discuss the, if we can over for these patients. I remember even discussing, the option to the patients from the clinic, with other colleagues. Sometimes they call me while the patient is there. Equipment, again, sometimes we have issues, obtaining the right equipment, and sometimes you have to work with whatever you have. Staff, you train them, they stay for a period of time, and then they have another opportunity. And this is, happen everywhere, even for us. When we have opportunity, we move. So it's very important to have a backup staff, not just one staff. Long-term follow-up is very important, and collaboration. And the future, we think, selection is very important for your patient, and personalized approach. You cannot apply the rule for all. Same-day procedure is probably in the way. We have issues here in Saudi because if you discharge them, you may not get them back through the ER. So they can stay in the ER for 5 days. So you have to be careful with the same-day procedure. Not sure about Egypt. Endoscopic management of complications, you have to be familiar and comfortable managing your complications. Complication will happen no matter what your curve is. But you have to be familiar and recognize them early and address them and also have backup of a good surgeon colleagues. Hybrid techniques also is the way to do. You know, if you have a patient with reflux, maybe you consider doing POEM F. And finally, before anything else, preparation is the key to success. Thank you.
Okay, well, thank you very much, Dr. Madkour, Dr. Alkhairi, for the nice presentation. And if there's one question, because we have 1 minute before we go to live, 10:30 we have to start live because...
Rasheed, Ahmed, excellent talk. Do you think in the future third space endoscopy will be in the curriculum of GI? Or it should be in sent certain person for the volume? I don't think it will be in the curriculum of GI in the future. Third space endoscopy.
So I think it's like anything else. You know, it's kind of an extra training or an extra skills. It's not for everyone to do. It's not needed. You don't need to have a third space endoscopist in every hospital. But I think, you need further training. You need to establish a program to have a competent trainee in the third space endoscopy, but not part of the GI. And I think, the third space endoscopy concept should be involved in the curriculum because our patient, when they go home, may end up, and probably will end up by a general gastroenterology, not third space endoscopist. So they have to be familiar with what we are doing, and sometimes they have to be familiar with, complications, management of complication, like Dr. Madkour is traveling a lot, he do the case, but he has colleagues, if things happen, they can manage.
Yes, I totally agree on this, and I agree to have orientation. Because sometimes you do a patient and he go home, have some pain, he do x-ray, and they found some air around the esophagus, and they say it's perforated, we have a catastrophe here, let's go. So this shouldn't happen if he is oriented, as Dr. Rasheed say, by the procedures and what he should found. And it would always be an add-on and advanced technique.
Yeah, so I mean, there's one point mentioned earlier, just emphasize really that everything starts with basics. So I mean, even just going through, this is more for the fellows. If you want to be a therapeutic endoscopy, you need to be a good endoscopist to start with. So you have a good colonoscopy technique to be a good therapeutic endoscopist, and then with also experience, once you are also a therapeutic endoscopist, knowing the basics, then you would be able also to do the third spacing as well. So